So as we wrap up today and yesterday, it's been a spectacular meeting. I want to start out by thanking Cheryl Nass and Sarah Therikin and the staff at the Institute of Medicine. And I think I can speak as both a member of the National Cancer Policy Forum and as the Senior Medical Officer of the American Cancer Society when I say that. I also want to thank Dr. Wolfe for chairing the session, and of course Rebecca Kirsch from the American Cancer Society for much of the momentum. Ralph DeVito of the American Cancer Society and his staff who actually did the work in raising the money for this meeting. In 3 minutes or less, we've had, I think what we saw the last day and a half is that we've had tremendous success in pediatric oncology, success actually not seen in adult oncology. I can say that as an adult solid tumor doc. Despite the success, we need to do better. We have had some amazing work in pediatric clinical trials with 60 to 70% of kids under the age of 12 being on clinical trials. Very few kids in their teen years and adolescent years on clinical trials, and we need to do better. Of course, we average 2 to 3% of adults on clinical trials today. When we talk about clinical trials and drug development in kids, there are some special problems and some special issues, many of which were discussed in the last day. We need to have more attention to short-term side effects and continue to give the attention that we have to long-term side effects and comorbidities due to treatment and cure. We need to perhaps count those comorbidities better, although I'm not sure how we can do that. We need to work hard to try to diminish those comorbidities as well. When we talk about side effects, we learn that we need to listen to the child and we need to listen to the family about symptoms and toxicities. Yesterday afternoon, we had some very moving and some very upsetting discussions about suffering, about the need for improvement of pediatric hospice, the need to improve palliative care, the need to separate palliative care from hospice. We had some people talk about what I prefer to call post-traumatic stress. It's not a disorder. It's actually a natural human reaction, post-traumatic stress. It's a normal response. We talked a lot about patients and families. I wish we had talked a little bit more about healthcare providers, especially nurses and doctors. Yesterday afternoon, someone was very upset that the doctors did not tell her and her family that her son was dying. I've been in that situation before, and let me tell you, sometimes it's hard for the doctor to accept that the patient is dying. And we sometimes don't address healthcare providers, especially nurses. We had some wonderful discussions this morning about the social determinants of health. I was especially moved by Dr. Kira Bona. Compelling discussions of the effects of poverty, of social condition. I'm not sure that by fixing social determinants of health at the time of diagnosis, we can do a great deal to fully address the problem. I actually think the time to address social determinants are from conception of the child rather than at the time of diagnosis of the disease. I'm still trying to digest the fact that we had some very sophisticated parents yesterday talk about their tremendous experiences in dealing with the system, and I'm thinking about very non-sophisticated people and how they deal with the system or don't deal with the system. Pediatric oncology is based largely in universities, and this is actually one of the reasons why there's such high clinical trials participation. There's very few private practice pediatric oncologists out there. they're salaried and they can spend more time with patients as opposed to private practice docs who really have to move patients along as a way of generating the revenue to keep the office going. Even though pediatric oncology is based heavily in universities, there's still issues with quality. There's issues with standardization, both in terms of diagnosis, in terms of treatment, in terms of psychosocial support, as was noted. Somebody said, I'm sure every clinic has at least one social worker. I'm not so sure that that's true. I think some clinics don't have any social workers still, and many clinics do lack. Standardization of therapy, standardization of palliative care are all issues that need to be addressed. Now, I, of course, am an adult doc, and I made my career doing a lot of studies of practice patterns. And let me tell you, coming from the adult world, we have huge problems in terms of standardization of treatment and availability of treatment. You know, one of the papers that I'm both most proudest of and most ashamed of as an American is a paper about how 7% of black women in the United States diagnosed with localized breast cancer get no treatment in the first year. When we talk about the adequacy of treatment in pediatrics, I was actually thinking, you know, there's a whole bunch of folks in the United States who really are not interested in human beings getting adequate care, and we need to work on that. Now, in terms of what can the American Cancer Society do, and the American Cancer Society Cancer Action Network, which is our advocacy affiliate, do not call them lobbyists, they are advocates. We can work to make these problems known and make people realize that these are real problems. Other groups, our colleagues from the American Society of Clinical Oncology are here. They can do that as well. Other organizations need to do it. These discussions for the last day and a half will be summarized in a publication, and hopefully it will help to bring added awareness of the problem. It's going to really require momentum. Big Mo comes from parents with anecdotal experiences going down Constitution Avenue and up some big white steps and talking to some people who have been elected. They listen to anecdotal experiences. We can give you the true numbers. We can give you a book summarizing or publication summarizing all of the problems, but ultimately it's the parents of the kid and the kid going and talking and working on trying to get these people to care. Keep in mind, as I said yesterday, we should not get into disease Olympics where we try to spite one disease for another, and we need to realize that if one cancer is bettered, all cancers are really bettered as you do that. That's the only thing I ask. I think that's the end of the day. Anything else?
My thanks, very, very briefly, ACS, IOM for sponsoring this. And I don't want to take anybody else's time, but just to acknowledge how amazing it has been to all be in the room together, to have broken down some of our silos and really sort of shared our thoughts and ideas. I recognize that not everybody is even in the room, and there's, sort of more need for these conversations moving forward because we've seen great ideas, heard the voices of families about screening, about interventions, and yet our challenge is we do need less variability across our centers, greater uniformity, greater access to measures to both continue monitoring and improve our care outcomes. And the next steps are simply how do we prioritize, How do we continue disseminate what we know? How do we continue refining based on novel work? And I think that these questions are important for us to answer as a community so that we can keep making great progress together. I will underscore that there will be a summary report in conjunction with the Childhood Cancer Awareness Month in September 2015. But I actually encourage everybody to lend their voice to this conversation and write perspectives on what you take away from this workshop. No one has ownership of the ideas that have emerged, and so share your ideas vastly and en masse so that we can continue to promote this agenda. Thanks and have a great day.